Welcome back, everyone, to another episode of the Preventive Medicine Podcast. If you are listening to this today, then it is currently Wednesday. I apologize for the late upload. The podcast episodes are normally supposed to come out on a Monday morning every 2 weeks. However, this is a very busy week for me, and a lot of different things just happen to kind of all fall into 1 week. Some of those going with my residency, some of those with other things that I'm involved in, and some of those for applications that I'm putting in for some additional things. So I apologize for the delay, but once again, this podcast is a hobby for mine, a hobby of mine. So if things kind of get busy on the professional and the career aspect, once again, I'm a resident physician, then this kind of falls a little bit by the wayside, but I apologize for that. The episode is live now, and this is actually a rebroadcast of an episode. If you are new here, my name is Dr. Raghav Sharma. I have been doing this podcast for about 2.5 years now, and this first episode actually aired in June of 2020, June 23rd, I believe, specifically, of 2020. And back when we started this podcast, it was myself and my co-host, Dr. Jason Garrett. We were both medical students at the time, and both of us were incredibly interested in just preventive medicine and talking to as many people as we could about kind of different topics related to preventive medicine. So the first podcast episode that we ever aired was actually with the magnanimous Dr. Austin Baraki of Barbell Medicine. If you have not already heard of them, then you probably should go check them out. But I'm assuming if you're listening to us, you probably have listened to them because they put out some absolutely incredible work. We cannot, or I cannot highly recommend them more. Go check out everything. I promote pretty much everything that they do. And Dr. Baraki specifically is an absolute fountain of knowledge. He is an incredible resource for everything when it comes to kind of internal medicine based stuff is what he does as his profession, but then also kind of strength, rehab, conditioning, all that kind of stuff. So go check it out. This episode is absolutely incredible. Dr. Garrett and I kind of both went our separate ways in residency. He gets a little bit more busy in his residency. He's an anesthesia resident, and I'm doing physical medicine and rehab. So we just kind of went our separate ways. There was absolutely no hard feelings. I asked him kind of if we could re-upload this, and he said absolutely. So I think there's a lot of value to be had in this episode, and a lot of new listeners. Thank you for listening. Might not have heard it yet, so please enjoy and welcome to the episode 1 of the Preventive Medicine Podcast. Overcoming saber-toothed tigers and woolly mammoths, we must now face a new enemy, ourselves. With the rates of diseases such as heart disease, stroke, diabetes, depression, and many others ballooning, we must find a better solution to these modern epidemics. Welcome to the Preventive Medicine Podcast. We believe in building a foundation of health by means of prevention so that you can build the life you want and find fulfillment with no barriers. Hear from experts around the country on how to take your health into your hands. Take control and build a foundation of health for the life that you want to live. And now, here's the show.
We are live with the Preventive Medicine Podcast. In today's episode, we welcome Dr. Austin Baraki. Austin is a physician specializing in internal medicine at a teaching institution in San Antonio, Texas. He attended medical school at Eastern Virginia Medical School in Norfolk, Virginia. Dr. Baraki is also the co-founder of Barbell Medicine, which he started with friend and former classmate Dr. Jordan Feigenbaum. Some areas of interest for Austin include application of strength training in the context of complex medical conditions, sarcopenia, pain neuroscience, and rehabilitation, as well as cognitive and sports psychology. So thank you for joining us today, Dr. Baraki.
Hey guys, thanks for having me.
Yeah, how are you doing today?
Doing all right. Just in between periods of time on the inpatient wards, so I'm wrapping up my little break period, and then I go back refreshed and ready to go. So how about you guys?
Nice. Good thing we're doing pretty good, hanging in there given the circumstances.
Yeah. Just kind of doing this online med school thing, which is super weird, but
I'm curious how it's going to be when I get the new interns coming in July who maybe haven't seen a patient in like 5 or 6 months, but we'll see. We'll see what it's like.
It might be rough for your senior resident there for a couple months.
Yes, that's what I'm anticipating.
So Austin, a lot of what you do outside of the 2 weeks when you're on that inpatient medicine is barbell medicine, correct? So can you tell us a little bit about what barbell medicine is, why you decided to start it, and like what the goals of that company are?
Yeah, sure. So I won't take credit as being a co-founder. It was entirely founded by my friend Jordan, who you mentioned earlier. But pretty early on in the process, when we ran into each other in medical school and realized that we had this shared interest we started working together, and that progressively increased over time. So this was, I guess it would have been probably around like 2013, 12, 13 timeframe, something like that. And so the idea, we came from and kind of an athletic background and had gotten into lifting weights. And as we went through the medical education and started to see more situations where kind of the exercise and lifestyle medicine, quote unquote, side of things could be applied to benefit patients, while at the same time seeing that it was probably being underemphasized relative to its importance. And so we kind of set out to serve as public communicators of this stuff. In other words, if their own doctors weren't up on this stuff, then we were going to try to deliver that message as broadly as we can to the general public, while at the same time also, by virtue of having attained this level of training and the professional degrees and things like that, that gives us some degree of like unique access to actually deliver the message to other clinicians as well, because they're more likely to listen to colleagues and things like that on these matters. So hopefully trying to influence both sides from the healthcare side, and hoping that might work its way up to broader kind of like policy type things and more public recommendations, as well as reaching the lay public on the importance of some of this stuff to improve public health outcomes.
Mm-hmm.
Interesting.
Are you able to actually? So I know a lot of it is coaching through barbell medicine, but when you're on like inpatient rounds, are you able to get people to talk about resistance training then, or is that kind of not the goal at that point?
Yeah, so I think in a lot of situations that's not necessarily the most immediate concern for somebody's like life or death
Yeah,
scenario.
obviously.
Somebody comes in septic shock, you're not worried about how much they can squat necessarily, but in the back of my mind, I am thinking, after this septic shock gets resolved, how much they can squat does kind of matter, because that might influence where they end up going. We start deciding about where a patient is going to be, going post hospitalization, basically at the time they get admitted. And I try to do that assessment pretty early. And, that might be a situation where I immediately know, unfortunately, this person doesn't have the physical capacity and they're going to end up having to go to a nursing home, which is less than ideal in many situations, versus, oh, this person's in great shape. Once we get this resolved, they're going to be able to go back home to their independent life again. And so while, we're not necessarily talking about it up front at the time that they come in super sick, potentially, it is a pretty regular discussion where we're talking about, what is their physical capacity? If you were to give them recommendations, what might those look like? Are you, the intern, medical student, et cetera, aware of what the physical activity recommendations would be? Because the same people that I'm training in the internal medicine residency, they also have outpatient blocks, and they have a continuity clinic and things like that. So it's like, let's say that you're going to do this patient's hospital follow-up. What kind of things might you be discussing with respect to their, if they come in telling you, man, after that ICU stay, I've had a lot, harder time getting in and out of chairs, getting in and out of my house, getting in and out of my car, et cetera. How would you approach that problem? So there are a whole host of ways that we can work it into the clinical discussion, regardless of where we are, whether outpatient, inpatient, ICU, et cetera. And that's kind of what I try to do, is I work it in with the teams and also with the patients themselves, because I might, do a little sit to stand test with a patient at the bedside. And when I see they can't stand up, then that might prompt a discussion of, how come, what can we do about this? What kind of things do you want to be able to do? How can we get there? Things like that. Pulling a little mini motivational intervention at the bedside can be useful.
Makes sense. So with all these other interests you have, specifically, we're talking about weightlifting or powerlifting, that sort of athletic background. What made you choose internal medicine versus something that's more, like ortho, bro?
Yeah.
Or PM&R.
Is
Can't
that
forget
is,
PM&R in their famous Kim
that's
medicine.
yeah, no, PM&R is legit, or it has the potential to be legit if people go about it the right way, I would say. Yeah, so I mean, it was kind of funny going through a lot of the clinical rotations. Sometimes walking in, the assumption was that I was going to go into ortho just because I like lifted weights, and I wouldn't say that my ultimate path into internal medicine was related to my prior like athletic history. It was strictly my personality and thinking style and things like that. I mean, I'm personally, I just really enjoy knowing a lot about a lot of things. and being able to explain the physiology, the pathophys, the pharmacologic mechanisms, the microbiology, whatever is going on. I like having a real deep understanding of that. And I like the process. I think probably in internal medicine, the process of differential diagnosis is like my favorite thing. When I can sit down with a student or an intern or a resident or whatever, and we have a patient presentation that might be vague or nonspecific or a bit nebulous up front, and we can work backwards through the physiology to figure out what are all the possibilities, where are all the steps that where this could go wrong, and that might guide our subsequent evaluation and management. So thinking through those possibilities is like what I really enjoy doing, and teaching people to think that way is pretty enjoyable as well. And on the other hand, I am about as strongly disinterested in procedural medicine as you can get. I definitely hate everything about the OR, and so that was not a place where I was gonna end up. I would sooner leave medicine than end up working in an OR.
Really, it's that bad?
Yeah. I'm
So
just not a fan.
yeah. So it's actually really interesting that someone has interests that are kind of not necessarily like diverging on opposite ends of the spectrum, but just like so much about internal medicine is not necessarily related to what you do through barbell medicine. And knowing a lot about the internal medicine side of things and just whatever goes into internal medicine and like barbell and strength sports and nutrition, all that is kind of, it's just a very broad amount of knowledge. And I think it's very unique that you have perspective that you can take from both sides and apply it to either your inpatient patients when you're seeing them on rounds, or taking your inpatient knowledge and then maybe applying it to some people you coach potentially. I don't know if you do that at all. I'm sure the perspective is beneficial at least. Do you think that more physicians that do not lift weights can learn from barbell medicine what they're doing, or do you think they should like go to your seminar or something like that?
Yeah. So I mean, I think that the there might be a bit of a branding issue there, in that when you call it barbell medicine, that might pigeonhole us a little bit in terms of what people might think that we do compared to what we actually do, which is a whole lot broader than just like lifting weights. So, the seminar that we teach is 2 days long. There's a whole bunch of lecture, and there's actual, lifting education, coaching that happen. But the overall themes that run through the seminar, and the themes that run through all the other things that we do, the content that we put out, the educational material that we produce, I would say that they're revolve around three major kind of pillars. The first is kind of our idea of health and what health is. And where there's been debates over the decades and centuries about what health is, and one of the more recent definitions that we like is that health is the ability to adapt and self-manage in the face of physical, emotional, and social stressors. And that idea of being able to adapt and self-manage is probably a novel concept with respect to health compared to what a lot of people might think of. They might think of it as like, oh, you got good blood pressure or something like that, right? Whereas the idea of self-efficacy as a theme for a healthy, robust individual to be able to take care of themselves in the majority of situations where that's feasible. Obviously, we don't expect them to self-manage their like ARDS or something like that, but in general, that concept is one overarching theme that we want to try to educate and empower people within their own kind of psychosocial, socioeconomic context to be able to do as much as they can, either for themselves or for their community, things like that. The second would be understanding how complicated most phenomena are, and in particular when it comes to humans, probably one of the best ways that we have to view this, although itself still limited, is kind of a biopsychosocial approach where we understand the physiology and the biology, which is obviously I enjoy a whole lot, but also understanding that, when we're dealing with people, we're dealing with psychology, we're dealing with their own socioeconomic context, which presents not, new things that we need to think about and consider, and that influence our plan, even if the underlying biology is the same between two different cases. Differences in the psychosocial context that those two cases are in can wildly alter what you end up doing or recommending for that person. So avoiding that reductionist perspective on things where you might isolate somebody down to their ejection fraction, instead realizing that they're a human and that maybe their medication adherence for their low ejection fraction is really complicated, and is due to a whole host of factors that need to be considered, and we need to give them the self-efficacy to be able to self-manage that. And then the third, to tie all those things together, is just the idea that most of this stuff that we're doing and promoting has to do with behavior change and how we go about promoting behavior change effectively. There's obviously a lot from a clinician standpoint, things you need to know, be aware of, as well as communication strategies, delivering narratives to your patients in ways that resonate with them and that will most effectively move them through these kind of the stages of change, as far as like a model that we have to conceptualize it. Although, of course, it's even more complicated than discrete stages. But being able to communicate with people at their level to help guide them through the process is a very difficult skill set to develop, and I think is also underemphasized in the course of medical training. So those are kind of like the big three themes that we have in our content. And I definitely would say that across the spectrum of physician specialties, regardless of what field you end up going into, those are overall good things to be aware of and potentially even competent with, depending on your degree of direct patient interaction. Like a hematopathologist's abilities to effectively perform motivational interviewing, not necessarily the most critical thing, but at the same time, recognizing that they're dealing with a person on the other side of that slide might still have some utility.
Sure.
And of course, now we're seeing these days with pandemic medicine, where people are getting pulled across specialty lines and all kinds of things. There's no situation where these skills would be a waste of time or unhelpful. So we definitely recommend getting familiar and comfortable with these ideas. And we've designed the seminar to be accessible to both lay people and to be useful for clinicians as well.
And that was kind of my next question is, do you find, having been to one of the seminars myself, I can definitely speak to how much it helped my knowledge base in terms of going forward as a doctor in training. But do you feel like as you do more and more seminars, that the population of them starts to trend one way or the other in terms of, lay people versus professionals?
I think we're seeing a pretty consistent composition. We're probably seeing about 3/4 lay people, 1/4 healthcare professionals, and that might nudge a little bit one way or the other, seminar by seminar, depending on the location. But I think that we've only been doing it for, let's see, maybe 2-ish years, something like that, and so there's definitely a long way to go in the future. And if we can, we may end up in a situation where we need to split them off into 2 separate deals, one for healthcare professionals exclusively and one for lay people. I'm not sure yet what direction that'll go, but obviously the people who do come through from the healthcare side, they end up leaving very enthusiastic and excited about this stuff and ready to help spread some of those ideas in their own local areas, which has been cool. And then additionally, sometimes that has then prompted them to maybe invite us to go speak at their respective institutions or places, which has also helped spread some of these ideas even more, which has been great.
For sure. So as we kind of break into the more, I guess, preventive medicine side of this interview and kind of get into some of the meat here, there are definitely a lot of kind of silly ideas surrounding the term preventive medicine, and just I guess in medicine in general, there's just a lot of interesting, probably bad ideas out there, especially when we're talking about nutrition, supplements, body care, whatever you want to say for, I guess, preventive health. So, what is your view in terms of balancing the evidence or the database with things that recommendations that we make in terms of preventive health?
Yeah, I mean, you alluded to a few things that are commonly discussed these days that can be silly, and I really don't think there's much of a counter argument here as far as why it's important to have data to guide our recommendations. All you really need to do is look back through medical history. If you look at any point prior to mid 20th century medicine, and probably in another 50 or 100 years, we'll look back on the current time period and say similar things. But if you look back through medical history, we have done some absolutely preposterously stupid stuff to either treat patients or under the guise of preventing issues from arising. You look back to the history of the 4 humors as like a guiding framework for medicine that existed for like hundreds of years, that people were doing all kinds of things, none of which were effective. But we continued to justify based on our observations that maybe this patient got better after we did something, and assumed some causation, and then another patient died after we did that thing, and we buried that one away and didn't pay as much attention to it. That led to the perpetuation a lot of these pseudoscientific ideas over time, until the point where we realized we need to maybe do some research on this stuff that can control for some of our observational biases. And so as that movement grew throughout the 20th century, we've started to debunk more and more things that are ineffective. But it's like a hydra. Every time you knock down one thing, either the person who's doing it doesn't change their mind because they say, oh, in my experience, it appears to work, which have been quoted as like the three most dangerous words in medicine is in my experience, or a whole bunch of new silly pseudoscientific treatments emerge, particularly as technology progresses. We get new technology. People view high tech things as like cutting edge, more potent, more likely to help. You get augmented placebo effects. They do something, they feel great, and then suddenly they're sold on the need for this new treatment that may have no basis in reality or physiology or evidence or something like that. And so, I think that also represents a failure to recognize how much harm we have the potential to do to people. One thing that I definitely try to emphasize, every time I'm on wards, it doesn't, you guys have already seen it in your rotations. I'm quite sure you don't have to be in this world very long before you start encountering iatrogenic harms. And every time I go on service, there's some fraction of the inpatient service that involves admissions due to iatrogenic events, right? Even if it's things that were all standard of care, like, oh, this patient has AFib, they got put on an anticoagulant, and now they're here with a GI bleed. Like, yeah, that's technically iatrogenic, even though they merited, the decision was deemed that the benefits outweighed the risks. They're here for bleeding, right? And there are just boatloads of those kind of things. And so I always point out to them to recognize, hey, you recognize this is an iatrogenic harm. We did this to this person, so that the students and interns and residents can start to actually understand how much responsibility they have in this with their recommendations. So it's one thing to cause some iatrogenic harm when we have ample evidence and data to say that the benefits outweigh the risks. For example, in that AFib example, maybe their CHADS VASC was like 7 and they needed the anticoagulant, even if they were at high bleeding risk. And you're like, well, that's kind of the way this thing shakes out. And sometimes it be like that. Alternatively, if it's a situation where there's no evidence to guide your decision making and you still recommend something and it causes harm, that's on you. That's like a big deal. It's one that you can shrug your shoulders about it, but when you started this thing and you guys went and you did I guess you probably still did white coat ceremonies and you took an oath to do no harm. That's the first thing you said was, before I do anything else, I'm going to try to do no harm. And so having data behind your recommendations whenever possible is super important. And when you don't, that needs to be an open, line of communication that, hey, we're doing this on a hunch, on a best guess. This may cause more harm than benefit, et cetera. To have, having true informed consent can be really difficult with some patients, depending on their level of education and things like that. But you at least got to try in those situations. If you're going to recommend something without data, it's best to not whenever possible.
Yeah, the beautiful thing about this podcast is that what I've learned to realize is that we have a bunch of different perspectives of people that come onto this podcast, and everyone seems to have a different idea, slightly, if at all, of what health is and what preventive medicine is. And I know you already touched on a little bit before with that definition of health being like your self-efficacy, or being able to maintain yourself in those different aspects of health, such as like your emotional, physical, and so forth. So with that being said, as well as what you just said about being careful about following the evidence and not doing more harm than good, what does preventive medicine mean to you?
Yeah, I think that in general, you'll probably get some degree of consensus on that question, as far as the idea of reducing the risk of preventable morbidity, mortality, helping people live longer, healthier lives. But I think the important thing to recognize when we're talking about preventative interventions or preventative care is that the overwhelming majority of this is going to involve things like health-related behaviors and social determinants of health, with a very small niche for things like biomedical interventions, screening, testing, drugs, things like that, from a preventative standpoint. And so I think that, it might be sexy for us to go down the route of doing more medicine and intervening more and doing more things that we can do, when really that should form arguably a much, much, much smaller piece of what this concept is about, compared to promoting, established beneficial health-related behaviors, and recognizing, which I think is an even bigger issue that is underappreciated, is the impact of a lot of these social determinants of health on ultimate health outcomes. Things like poverty, isolation, things like that. There's just paper I shared, I think it was yesterday, on the impact of the attributable risk of cardiovascular health outcomes attributable to poverty itself. So tons of things that we're not doing enough about, while we're getting super excited to check the box on our EMR that we're meeting our preventative testing recommendations to send somebody for a screening intervention that has like a number needed to treat of 1,000 or something like that. So
Yeah.
I can
So
definitely
I think,
appreciate. Oh, go ahead. Sorry.
oh, go ahead.
I
I was
was
just
just
going to say,
gonna say.
basically,
I'll edit
it
this
must be like
part
a little
out.
bit of a lag here.
I'll edit this part. There is a lag. Go ahead.
So basically, I was just saying, yeah, I think one of the things that Raghav and I thought about when starting this podcast was definitely way more on the side of behavior change and that sort of thing versus testing and all of the technology and things that kind of get thrown into preventive medicine. But I definitely think that we struggle a lot as a healthcare profession to either find the time to recommend those things or not have the adequate knowledge base to recommend the right dose of exercise and the right nutrition recommendations and things like that. So I think it ends up being just a cluster of different recommendations, some evidence-based, a lot not evidence-based, and people really don't know where to go because one doctor says this, one doctor says that. And there's not really that, same, I guess, diagnostic and therapeutic requirements to learn the same drugs and the same pharmacology and the same, I guess, more of the quote unquote like medicine side of things.
Yeah, adding on to that, I was going to say that a lot of the things that you talked about in terms of preventive medicine, which are beneficial, like talking about the social determinants of health and whatnot that goes into that, is a lot harder to do because you have to like address systemic change. So not systematic. And there's so many different things to address when it comes to that, and trying to get people access to better food, to like actually exercise. Because I know we can always say just exercise and eat right. But to someone that doesn't have like the proper things like in their background to be able to do that safely or effectively or be able to afford food, then it's a lot more difficult to do. And I think a lot of the reasons that a lot of physicians these days talk about preventive health is just kind of that screening thing, is because it's easy to do. You kind of just order it. The
Yep.
patient goes somewhere if they can or if they can't. It doesn't matter the physician. They just check that box off and say, all right, this person got their screening and they're good to go. Preventive medicine, check.
Yeah, you're totally right. I mean, the stuff that matters is really hard to do, and the stuff that's easy to do matters very little in comparison. Uh, and so in the course of a busy workday, some clinics themselves, the way they're set up, presents a barrier of its own in terms of how many patients you have to see, how much time you have available, et cetera. So you're right, top to bottom throughout society, there are just enormous barriers to this stuff, and that's kind of why it's important to the extent that you're going to make comments about the importance of preventive medicine, you probably need to be an advocate on a much larger scale rather than patting yourself on the back for ordering somebody a low dose chest CT for their lung cancer screening, which like barely does anything. So
so kind of piggybacking on the screening idea. So, I mean, you run into screening in, screening versus diagnostic testing all the time. It's something you've talked about quite a bit on some previous podcasts you've done recently. When it comes to teaching your medical students and residents and just teaching the general public and patients, and you talk about screening tests, what's one thing that you kind of would like to get across to different physicians or just people in general about why the allure of more screening is problematic?
Yeah. So I don't know that I can reduce it down to one thing. I can give a bit of a spiel, I guess, on the topic and see where it takes us. I think that when I'm working with the students and the residents, I think one important point of distinction is difference between diagnosis and screening. And so, a lot of times in the inpatient setting, we're dealing with patients who are presenting with symptoms, and we're tasked with trying to figure out a diagnosis and a treatment that can then, alter the natural history of that condition. And that obviously in that context, I'm encouraging them, working with them to learn about developing a good differential diagnosis, understanding like Bayesian inference, where they can have an idea of where their pre-test probabilities are, what they want to do to alter their post-test probabilities in terms of history, examination, ordering tests, things like that. Having an idea of the test performance characteristics. You don't have to know the exact percentage of sensitivities and specificities and things like that, but having an idea of how likely is this test to alter my thinking and subsequent management in this patient. Anticipating your plans at least a couple steps in advance is something that can be really tough to do when you're earlier on in your training. And so the idea of, hey, you say you want to order this test. This is an academic institution. I'm okay with letting you order this test if you'd like, but I want you to consider, what are you going to do with the information that you get? What if it shows you this? What are you going to do? What if it shows you that? What are you going to do? Are those answers the same? Okay, let's just not do this thing. As an example. So avoiding shotgun labs, avoiding routine labs that aren't necessarily indicated, a lot of times daily labs, just having more numbers to present on rounds seems like, you have more data, you're better prepared. Ordering echoes for a syncope patient with a normal EKG that doesn't need an echo, and then you're going to find stuff that's going to lead to more testing and intervention, and then somebody's going to recommend they get Q6 monthly echoes for the rest of their life or something. So there's all kinds of consequences, and again, that's just basically conveying the degree of responsibility that they have and the amount of harm that they can do, whether iatrogenic medical harms or psychological harm, financial harm, et cetera, that you can do to somebody by finding something that didn't need to be found, even in the course of a diagnostic workup. When it comes to screening, the task that we have is even harder, because we're looking at asymptomatic individuals in the context of screening, and doing things to people who look fine and feel fine, uh, searching for problems under the guise of preventing downstream morbidity and mortality is even harder to do in somebody who has no symptoms, no complaints, and overall looks okay. And so in that situation, we need even more evidence of benefit with respect to morbidity and mortality if we're going to be taking what would have been called healthy people and turning them into patients. If you're going to do that, you better have some good evidence behind what you're doing, that it's actually going to help the person, because in the absence of evidence of benefit, all you have is potential for harm. And so, just a common example, if you go through a general continuity clinic for general medicine doing primary care annuals, quote unquote, and they want to do an annual CBC on this person, it's like, okay, why? Is there evidence to support annual screening for somebody's white blood cell count and hemoglobin, et cetera? No, you don't need to do that. So I think, the way I approach this in practice with them is, basically when they want to do something, I ask them to either support what they're doing with evidence or support what they're doing with an explanation of how this is going to alter their subsequent diagnostic reasoning, their subsequent therapeutic plan, et cetera. Because there needs to be some tangible benefit to be had by doing a particular test or evaluation. Whereas if I ask them how this is going to help, either in the current diagnostic process or from a screening standpoint, and I get a shrug, then I'm forced to think that the seesaw is tilted exclusively in the direction of harm here. And so I'm unconvinced that we need to do this.
Yeah. Being the academic
So
physician
go
you
ahead,
are,
Raghav.
sorry. Once again, we're going to run to this problem a little bit, I think.
It's okay.
But I was going to say, being the academic physician you are, you of course had us do some homework before this episode, and both of us read Overdiagnosed, which was honestly a really good book, and I appreciated that you had us to read that because it opened my eyes to a lot of things that you're talking about right now, and a lot of the problems that we are going to face in medicine more and more. With the increasing capabilities of technology and so forth. And one of the things I talk about in that book is really that one of the barriers to prescribing less tests and less screening measures is that they're kind of sold to patients and to physicians saying these are beneficial. So when you look at a patient or when you look at like a ad targeted towards a patient or to the lay public, they see, all right, we can catch prostate cancer before it happens and
Yeah.
I'll be saved from cancer, which is
Yeah.
cancer is bad, right? So how do you kind of balance? And then on the other side, when you have physicians that are like on the checkbox model where they can check off that preventive care, it's very alluring just to be able to say, all right, we order this for the patient. So the question here is, how do you kind of fight that in a sense or battle the allure of both physicians checking that and then the patients coming to you and saying, hey, I want to make sure I don't have cancer. How do I
Yeah.
get this test?
Yeah. Yeah. Yeah, this is similar to what we were discussing earlier. The problem crosses multiple layers and multiple levels here. Obviously, there's the understanding among the lay public of cancer, like you said, for as an example of something we screen for. Cancer is bad. The assumption is that early detection is always better. The idea that more information is always better. Furthermore, and all of this with respect to cancer is kind of underlined by the assumption that once you have cancer, it will inexorably progress and cause badness down the line, which I think that's probably like the biggest fallacy here. And that just represents a misunderstanding of cancer biology and the result of both poor dissemination of this information as well as a lot of like the public health kind of campaigns around cancer and cancer screening are like extremely emotionally driven in a lot of contexts, right? Because almost everybody knows somebody who's had cancer, and whether they
Mhm.
had a good outcome or not, it's a very challenging, taxing, emotional experience. And then that drives the desire, oh, that could be me. I need to know, do I have cancer? If I have cancer, that's gonna progress and it's gonna be awful, etc. Whereas in reality, just about everybody has cancer in some capacity, i.e., like malignant cells that can crop up here and there, right? And as you guys probably learned in your immunology class, we have this amazing like immune surveillance system that can go through and take care of a lot of those things, such that we, to whatever extent we develop unknown pre-malignant or malignant lesions, that they can in many cases regress, or in other contexts they may not progress. They may be slow growing indolent lesions that never go on to cause any problems at all. And this is just a reflection of the huge heterogeneity in cancer biology as one specific example of something that we screened for. And I think that, people might have a difficult time adequately weighing the risks and the benefits here. So they might say, I don't really care what the harms are of getting this test done. I'm not worried about any of that stuff. If it can find cancer, it'll save my life. The assumption is that if a screening test finds something, then it has therefore worked and it saved your life. And that's another huge fallacy, because that gets to the idea of overdiagnosis, just diagnosing things that were never destined to cause any morbidity, any mortality, any symptoms at all in many cases. And this is something where looking back through medical history again can be very educational and informative if you look through various screening interventions that have been done in the past, such as thyroid cancer screening. There's been a bunch of screening programs in pediatric populations, neonates, that have then ultimately led to the where newborn screening is today. Which is more based on evidence than it has been in the past, and just a whole bunch of things that we've realized that, hey, we screened a ton, we found a ton, because that's what screening does, with very highly sensitive tests. You catch all the true positives, you catch a bunch of false positives that require subsequent confirmatory evaluation, and when you catch something, you are usually inclined to do something about it, right? Because that's the idea when you're thinking a step ahead with your test. I'm doing this test because if I find something, I'm going to do something about it. And that might involve treatment, that might involve surgery, chemotherapy, radiation, whatever, or ongoing imaging follow-ups for the rest of your life, or whatever the case is, whatever plan of action there's going to be. And all of those things can have accumulated harms that ultimately may outweigh any potential benefit in the case of an overdiagnosed case that was never destined to cause any problems. And then at the top layer, that's kind of what you're talking about. So there's the patient level assumptions about more information always being better, which is definitively not the case. There's kind of clinician understandings of this stuff, and then kind of the systemic incentives that are at play. So an example of this that you kind of alluded to was like the checkbox and these quality metrics that somebody might be their practice performance might be evaluated against these quality metrics. And of course, all the quality metrics themselves should be based in evidence, right? They should be like, oh, we have good evidence that if you actually perform better on this, that it'll help patients. But of course, there's that idea that once you start measuring something and that measure itself becomes the target, you might be missing the actual forest for the trees there. So the underlying point here is that a lot of these screening interventions, the clinicians themselves don't even have a good understanding of how much benefit they stand to offer patients compared to the potential harms. And so one way that I like to address this is there are an increasing number of kind of clinical decision-making tools available that can help to guide these conversations, and they can help to guide them by even producing like visual pictorial illustrations of NNTs and NNHs, for example, because we'll have, for just an example that I might come across regularly, we might admit somebody who's in maybe their late 70s to the hospital for some COPD exacerbation or something like that, and the intern might recognize, oh, they have an iron deficiency anemia, and therefore obviously that's colon cancer until proven otherwise, iron deficiency anemia. So they should probably undergo this diagnostic evaluation. Or even if there's not any evidence, they might say, oh, they're due for their next screening in, again, an asymptomatic person where you're not pursuing that diagnostic evaluation. Well, we have patient decision-making tools where we can input all the information, demographic information about this patient, and it can give us a better idea of what are the odds that this patient actually benefits from undergoing that sort of an evaluation compared to what are the odds that they are more likely to be harmed. And almost universally, whenever I prompt them to go through that exercise using one of these tools, like the UCSF ePrognosis tool, their jaws drop at the end. They're like, oh, wow, I wouldn't do this if I were the patient. And I'm like, that's exactly what I want you to be thinking about. What would you do if you were in this situation? What would you want your parent to do if they were in this situation? Because it's really easy to tell a patient, just go do this. But when you actually are faced with those kind of benefit and harm trade-offs, what would you actually do? And very often they end up realizing, oh, we have a lot more potential to harm this person than to help them. Maybe this isn't the best idea from a preventative standpoint if our goal is to actually, promote quality of life, quantity of life, health span, things like that.
Makes sense. And I think one of the things that stood out the most in that book, and we've had a lot of conversations like this, Austin, where basically it's, if a cure is necessary, is it possible? And if it's possible, is it necessary? Right. So I think like you were talking about, I think so many people have this maybe false idea that we can cure everything that we can catch early. Right. So it's like, well, if we catch this cancer, like we used the example of cancer earlier, if we catch it earlier, we'll be able to treat it better. And that's a lot of the times not the case. And cancers that we can catch earlier, things that we can catch early, a lot of times don't benefit the patient to treat early until they become symptomatic. And things that, we would like to be able to catch early are the things that we currently aren't able to catch early or don't have good treatments, even if we catch them early. So I think there tends to be this, I guess, error in the mind of the patient that, well, if I find it, they'll be able to treat it. And then also the error of commission on the side of the physicians of, well, I need to do more for this patient, not less. So what more can I do to help them, do things or prevent things?
Oh, yeah. Yeah. I mean, even culturally, this is kind of ingrained in the process. So I might have a student or an intern presenting a situation on rounds, and they come up with their problem list, and every problem they go through, the question's, all right, what's your plan for that? And that there's kind of like an implication there of like, you need to be doing something about that. Whereas ideally, it's like, it's perfectly okay to say, I don't think this needs intervention. But there's this jump to, I want to make sure, I want to come across as being very on top of things. I want to have a plan for every problem this person has. Whereas like maybe most of them, you can just like let it ride and they'll be okay.
Mm-hmm.
Yeah, I think from a lot of what we just discussed right now may apply more to physicians and clinicians and people with like a background in this, though. So let's say I'm like a general layperson coming in who wants to get a whole body scan because whole body
Oh,
scans let me know
Jesus.
whatever's going on in the body, right? And then I can find out if I have something going on in my chest, something in my legs, whatever, so I know. And then in one of our previous podcasts with Dr. John White from WebMD, he talked about communication and how that's one of the biggest aspects of preventive medicine and being able to communicate what you know and the proper knowledge to the patient. So what do you tell a patient? Like, how do you communicate it to them so that they understand if they want to get a whole body scan?
Yeah. Yeah. So I'll preface this by saying I never jump to tell people things. That's never going to be the first step in this situation. The first step when they say that is going to be tell me why. Tell me where you got this idea from. Tell me what you know about this. That's almost always, I mean, across all the contexts that I'm in, whether it's a outpatient consultation, inpatient consultation, a coaching situation, the idea is first I want to elicit where they're at so that I can reflect back to them. I'm paying attention to the words they use, the language they speak. I try to get a sense of their education level. I try to get a sense of where this came from so that I can address them kind of at their level. And so maybe they just said, oh, I saw this highway billboard sign to get full body MRIs or something like that, and so I thought it would be a great idea. Well, that gives me one
That's source of
avenue.
information.
Right. So that gives me one avenue that I can start going down as far as the potential the potential benefits of that, the potential risks of that, and kind of where this trade-off ultimately shakes out. Whereas if they got told it by another doctor or by another trusted friend who maybe they heard it from a friend who went through it and they found something, there's a whole lot of ways that you can get your foot in the door in these conversations, but just jamming your foot through the door right off the bat is never the right way to go when you're having these conversations. So always start out by eliciting what their initial understanding is and using that to work through it. And then from there, basically, I would aim to enlighten them or to help them understand that there are potential harms to this. And that for people who feel fine, searching for every abnormality in their body, the idea of not wanting to miss anything means you end up catching everything. And just because you catch everything, a lot of it is probably going to be of no consequence, and helping them understand that our bodies are pretty remarkable things. They can take care of themselves in a lot of ways, right? Like just the physiology involved in like maintaining your own normal sodium level is pretty impressive. That's going on there. And so a lot of these things, just because we catch it doesn't mean that we need to do anything about it, that people aren't fundamentally broken, or that they don't have dangerous, ominous things going on under the hood, because a lot of people use these kind of like mechanical type analogies to describe things. And so I think that I would start with that, and then to establish some confidence in the shared plan, I would actually follow that up with recommendations for the things that do work, rather than just dismissing them and saying, "Nah, we're not going to do that. Go home." Rather saying, I don't think that that's necessarily the best thing that we can do for you here, but here are the things that are likely to give you the most benefit, for example. And there are, a small handful of things that would be very strongly recommended from a screening preventative standpoint that we can do, so that you're establishing a plan that is based in evidence, and you're demonstrating to them that you understand where they're coming from with their concerns about the potential for future disease and death. And here are the things that we know that we can do to provide you with benefit.
Raga, do you have a comment? I just didn't want to cut you off there.
Yeah.
And you look like you wanted to
I
say
was waiting
something.
for the same thing. I was gonna build that into the next part of this, where we were talking a lot about how we want to educate the patient, both from educate the patient and other physicians on the benefits and harms of screening, and different ideas when it goes to preventive medicine in that regard. But you also touched on educating patients, which has to do with a lot of what Jason and I talk about, both amongst ourselves and with other guests, is that we want to build a resilient patient population where they have a high self-image or high self-efficacy of themselves, which is also what we talked about with our model of health. So with that, why is it so important that patients are educated and have a high self-efficacy? Like, why is it important to have a high narrative in a sense?
Yeah. So the narratives that we build around health and around various health conditions have enormous consequence. downstream. And this is definitely something that is underappreciated across a lot of fields. I'll say if you're ending up in PM&R, that's one where this can be problematic in a lot of cases. Just pain medicine in general, it can be really problematic in this context. But yeah, I think you can look across just about every medical condition or every medical scenario, and there actually is an enormous body of evidence on the importance of self-efficacy and the association of it with better outcomes. When patients feel like they have the skills, the strategies, the knowledge, the ability to take care of themselves in various conditions, outcomes are going to be better compared to the opposite, which is more of a learned helplessness scenario. Medical dependence, things like that are situations that tend to result in much worse outcomes. So we definitely want to promote that to whatever extent is possible, and giving people things that they can feel more in control of to kind of guide their own, chart their own path throughout times of suffering, disease, things like that. But definitely, I mean, patients listen to us. They listen to us more than we think. It's easy to get jaded and say, this patient's never going to do what I tell them to do, even though that's not the way to go about this kind of conversation. But people listen to it. We are held in a position of authority more than we can appreciate in a lot of times. And on top of that, again, we took this oath to do no harm. We do systematically tend to overestimate our benefits and underestimate our harms. With respect to the things that we can do and offer to our patients. And one of the biggest places where we underestimate our harms is our use of language with people. The language we use around certain conditions itself can really set people up for success or failure. And I would not say that that is an exaggeration or an overstatement based on a lot of the available evidence, particularly in the pain musculoskeletal rehabilitation world, where the language that's used when discussing certain patient conditions, it can set them up for a lifetime of disability, fear avoidance behavior, kinesiophobia, things like that. On the other hand, more optimistic language and discussions of patients' conditions in a way that does tend to promote more of this self-efficacy, gives them a role to play in their own health. That tends to flip things in the other direction. People tend to have much better outcomes from this, even if their pain intensity, even if they continue to live with some degree of pain, we don't get their pain score to 0, because oftentimes that's an unrealistic target. They're able to live better in the face of that discomfort. They're able to engage with life, do the things they want to do, not lose their sense of self and autonomy as a human. And this extends not just in the pain rehabilitation world, but across a whole host of other situations as well. And there's ample evidence of this as well. Even, one example, when I'm talking about the pain conversation, like low back pain being as hugely prevalent as it is, there's even data on, just rewording radiology reports, right? Whereas instead of saying severe multi-level degenerative disc disease, right, saying age-related changes, when you're having the conversation about this with the patient itself, can change their whole conception of what's going on with themselves, whether they're fragile, whether they're about to walk outside and be paralyzed by turning the wrong way, or whether they can continue to move because that's kind of an expected finding, maybe in somebody who's 75 years old or something like that. So definitely an underappreciated thing. And when I am rounding with teams, and always getting them to sit down at the bedside and sit at the patient's eye level and have these kind of conversations with them, I'm listening just as intently to what the student or the intern or the resident is saying and how they're saying it as I am to what the patient's saying. And then we debrief after we leave the room to say, you noticed how you said this particular phrase. I would have said it this way. I would have explained it a little bit differently, et cetera, so that we can kind of nudge them in the right direction over time.
So with that being said, I think it's like you said, I think one of the things that patients take away from their visits to the doctor, whether for screening or for, symptomatic diagnosis, whatever, is a change in the view of self, right? So if you end up with, you come to the doctor with shortness of breath, whatever, the symptoms of heart failure, and you get diagnosed with heart failure, guess what? Your view of yourself just changed.
Yeah.
Because you went from, well, I thought I was a healthy 50-something-year-old person to now I carry this big diagnosis that sounds scary and has probably large implications on my not only quantity of life, but my quality of life. So I think in terms of screening and the terms and diagnosis we give people, we need to be very careful about what impact that's going to put on how they view themselves. But saying that, do you think that a person's narrative like of themselves can in a way be preventive? If I think, well, I'm a pretty resilient person, I can handle a lot. Do you think that's something that actually goes into preventive medicine in terms of the way a person views themselves and their health? Or is that kind of just a little bit wishy-washy?
I mean, I see examples of that pretty frequently, where people's narratives, self concept, their self efficacy, things like that, can influence their own subsequent behaviors, their degree to which they end up using the healthcare system, and therefore the degree to which they're exposed to the risks of the healthcare system. Right. So that in my coaching side of things, when I'm coaching athletes and things like that, very frequently nowadays, after I've been coaching people, I have several people I've been coaching for 7 or 8 years, and one of them might tell me, "Oh yeah, I tweaked my back like 2 or 3 weeks ago. It happened. I was having pretty severe back pain for a few days, but I knew what to do. I knew how to take care of it, and I just didn't bother telling you. I just fixed it myself, and now here we are. So we're back on track." And I'm like, that is amazing. That is awesome. That like makes my day. Versus a situation where it's a very different situation when I have somebody who says, "I tweaked my back. I was worried that I was going to be paralyzed, so I went to an ER. I underwent a stat MRI for my acute non-specific low back pain, and then they consulted a surgeon who told me I was gonna need to get a spine surgery within the next 5 years if I don't stop lifting or something like that." Right. So those are two drastically different scenarios, and the two different ways that this plays out can have huge implications. On one hand, I have somebody who is high degree of self-efficacy, high degree of confidence in their ability to self-manage this condition, and they took care of it in normal, kind of the normal natural history of acute non-specific low back pain, for example, resolving in a couple weeks, compared to the other person who not only did they not have that confidence, they had a lot of fear, anxiety about the issue. They pursued the immediate medical evaluation, which itself is not inherently bad, right? If you don't know what to do, it's okay to do that. But then that's when they get exposed to the harms of the medical system. Potentially, if you're seeing people who don't necessarily know how to manage this condition in an evidence-based fashion. Of course, if you show up to an ER, their rule 100% sensitivity for bad things. I'm going to try to find anything that's bad. But then at the same time, how do you have the conversation with the patient when you don't find anything that's bad? And that's what can then alter their life trajectory. Maybe they're like, "Oh, I can never lift anything again because I had back pain once." That has huge implications, because now automatically they're no longer able to meet current physical activity guidelines because they can't do resistance training, can't from their own perspective. Now they no longer feel they can do that. And maybe because they feel like they can't do that, then they self-select for a decreased level of physical activity. They might gain some weight. They might develop sleep apnea. They might develop fatty liver, cardiovascular disease. They might develop all kinds of medical downstream complications that were, if you back up, attributable to the narratives that they had about things that they experienced. I see this actually quite commonly in some of the military population that we see people who get out and maybe they have some back pain and they're told that they have like disc degeneration and so they can't exercise, quote unquote. And then later on, you're seeing them in the in the cardiology clinic for their AFib that's due to sleep apnea. You're seeing them in the hepatology clinic for their fatty liver disease. You're seeing them in various other places developing these medical complications that were, when you look back, potentially avoidable through some of this stuff, because maybe the condition that they were told they had was not a contraindication to ongoing activity, but the way that it was framed and explained to them painted it as such. And that's just an example of like an underappreciated harm of the language and the narratives that we use around this stuff.
Yeah, you straight up like took the words right out of my mouth as the downward spiral, as you were describing as a patient, that they get told something or they have a very minor injury. And next thing you know, they're like, all right, I can't squat anymore. I can't do any exercise anymore. Otherwise, I'm going to break my knee. I'm going to pop open my disc in my lower back, whatever happens. And then a lot of times it's that downward spiral. If they don't exercise, they get scared to exercise. And then whatever intensity they used to have in their exercises, completely thrown out the window. So it's definitely a difficult line, and it's also a very narrow line between when a patient has a very high self-efficacy, or if they're like right on the line of like that higher self-efficacy and lower, where they could easily become a very medicalized patient, or they could be like a resilient patient, as we're talking about. And Jason and I are both of the mindset of that we think preventive medicine is a lot about setting the patient up for success so that they can do a lot of things themselves and not necessarily need the healthcare system. Obviously, the healthcare system is great at what it does in certain aspects, but as you're talking about, it also can do a lot of harm. So you want to have that balance where the patient is able to do a lot for themselves and be able to utilize the healthcare system when needed. And a lot of that comes with having that positive self-image. If they're able to build that up, through like over time of like little wins is what I talk about. A lot of little wins together. They have a high self-image and they can kind of figure things out for themselves and know when to use a healthcare system versus kind of just relying on it and then reading those billboards and saying, oh, maybe I should get this full body MRI.
Yeah, one way that I've seen this discussed that I really liked was the idea of, you may be familiar with the idea of universal precautions, like in the hospital with respect to, hand washing
Yeah.
and hygiene and things like that. And so one example would be, let's say somebody shows up with an acute pain related issue, just applying universal precautions to everybody that you see in that scenario, in the sense of treating them as if they are somebody who can progress to like a persistent debilitating pain state. In other words, doing everything you can to avert that clinical trajectory early on, rather than just treating them, maybe blowing the issue off or something. And then if they do end up progressing, then you're in a much deeper hole to try to dig yourself out of with that person. So universal precautions with respect to treating everybody as if they could progress to being more dependent on the healthcare system, and doing what you can to avert that earlier on is probably a good move.
So with all this being said about kind of keeping people out of hospitals, I think one of the things we would all agree that is a big part of that is exercise. I mean, one of the strongest recommendations we can give people is exercise. And I think, one of the things that I think a lot of even clinicians don't realize is that the current guidelines for exercise are relatively robust in terms of the amount of resistance training they're recommending and the amount of vigorous exercise or moderate intensity cardiovascular exercise. It's a pretty robust amount of exercise. And I think, or I guess I should say, do you think that we do a pretty poor job of explaining to patients that hard exercise is something you should be striving for?
Yeah, so I think that this is definitely a nuanced conversation, as we'd say. I agree.
I was waiting for you to drop that word.
I agree that the amount is pretty substantial. So, 150 to 300 minutes of moderate intensity, 75 to 150 minutes of vigorous intensity, and 2 to 3 resistance training days per week. That's a lot of work for most people. And I think that, it is definitely, there's a large and robust body of evidence that if we can achieve those as minimums, then we can have enormous health implications and benefits for people. However, I think that it's also important to recognize that there's no minimum threshold for benefit here either. There is no minimum threshold at all, and there's a dose response effect with respect to the training volume that you do. So you can start out with a little and get a pretty substantial amount of benefit, and as that volume dose increases, you get incremental benefits over time. Definitely, I think that clinicians' ability to confidently converse on this stuff is pretty poor overall across the board, including most primary care folks. Their ability to deliver this information in an effective way, i.e. using effective behavior change techniques, is pretty poor. Of course, it's also limited by the time they have available and things like that. How often do patients ever schedule appointments with the primary care doctor just to discuss exercise? Like, Never. They don't do that. And so you're always forced to be cramming that in, maybe at the end of a visit, after you've discussed either a chief complaint, or if no complaints, their other, multi-morbidities or their screenings or whatever, things that are potentially of lesser significance to their ultimate health outcomes compared to exercise. But that's kind of the world we live in right now. So I definitely think that there are communication issues, but there are problems at multiple other levels here. And I do think that similarly to our conversation earlier, by starting out by trying to elicit where the patient is, can be more effective, so that you can deliver them the information in a way that they can understand, and it can be a realistic starting point for them. So if you have a 65-year-old person with a few comorbidities who's never done anything physical in their entire life, giving them a piece of paper with these physical activity guidelines is equally effective as putting that piece of paper in the trash. Like, it's not going to do anything. Whereas eliciting where they're at, what their goals are, what they're able to do, and proposing some specific things that they can do, rather than just general things like move more. Like, what does that even mean? So I think there are just so many ways that we can improve the way we deliver this message. It needs to be individualized 100% of the time. Based on their baseline abilities, their tolerance, their goals, their preferences, things like that. And there may be some patients who just straight up say, I'm not interested in doing this. And then that becomes a process that you might work on over time. They teach you guys in school. They taught me same way. If you have somebody who, is actively smoking and they say, I'm not interested, what do? You bring it up the next time. You don't just say, screw it, this person's never going to quit smoking. You just keep doing it because the benefits are so huge, right? So it's easy to, for some reason, we get uniquely jaded about the ability to actually elicit behavior change with respect to exercise, even though the evidence base we have on this says that we can change behavior. But you have to view it as an intervention that has its own unique number needed to treat, just like anything else. In other words, maybe it might take, if you really suck at this stuff, maybe your NNT for exercise related behavior change is like 500. You counsel 500 people, you might get one to actually change their behavior. Whereas if you are really, really good at this, maybe you can work that NNT down to, 20, 15, maybe 10 or something like that. That'd be super impressive, is if you can have potentially even lower by how many people you need to counsel before you can get one to change their behavior, even if a little bit, because again, there's no minimum threshold and there's a volume-based dose response to the benefits over time.
And that comes down a lot to, once again, currently where the system's at, because we talked about this in another podcast as well, where the incentives are, because getting a patient to change their behavior regarding exercise and nutrition is pretty difficult to do especially if they're like resistant to it.
It's
and it takes a lot of time.
Well.
Yeah, it's very time intensive. And if you go to like one of those ICD-10 codes, it's not really on there because it prefers interventions, right? So the amount of time that physician has to spend to get a patient to do that is kind of not balanced how much compensation they get out of it, which is one of the major problems that hopefully gets fixed by the time we get further on in our careers. But I think that would be huge.
Yeah, I think so too. And the other thing that may end up emerging from this, and this is something that you already see in some primary care clinics with respect to nutrition, for example, is that there may be a dietitian in the clinic and that they can function as a part of a modality, multi-specialty team, because it might not be feasible or realistic, or even it might not even be the right idea for a physician to be doing this counseling exclusively, because basically you want everybody in the clinic to be practicing to like the top of their like level of training and their license in terms of scope. And that might not be the best use of a physician's time in a situation where you might have access to somebody who can do that counseling effectively on their own and may have more time to devote to it. So there are, growing aspects to this kind of specialty, multidisciplinary care, where maybe there is going to ultimately end up being, a dietitian who can handle that piece, maybe somebody who's like an exercise counselor, whatever title you might want to give them, who can help to facilitate that side of things. And that might, I would expect that would become more prevalent when the incentives align to facilitate that, of course.
I agree. I think one of the things as well that currently seems to be a barrier, but hopefully, I guess as social media and other outlets such as, you guys at Barbell Medicine spread a message of, exercise and nutrition and things that are actually important. There seems to be a disconnect between I guess I would say like personal trainers or fitness people and physicians in terms of, physicians get frustrated because so-and-so, this personal trainer with 1 million followers is selling some sort of, bullshit product. But then a lot of, personal trainers like, well, the doctor doesn't know anything about nutrition or exercise or whatever. So, how do you, in your mind, what do you think the steps are towards bridging that gap between, okay, we have fitness professionals who know how and what to recommend and physicians who trust them to make those recommendations and vice versa? How do you see that playing out in the next decade or so?
Yeah. I'm not sure I see a ton of progress being made on that front in the next decade. Might be over a longer period of time, but that's a reflection on my own views on a lot of things. But I mean, I think that it's easy to pick out examples of bad apples like that. There are people who espouse non-evidence-based or outright harmful information all over the place. And so that does not that even includes physicians. I mean, physicians like to hate on a lot of other groups or specialties, or say they might mock a lot of forms of complementary and alternative medicine. And by no means am I a huge fan of those things. But at the same time, if you're going to be doing that, I would expect that you're at least practicing in a pretty evidence-based fashion. And when we look at how often clinicians actually adhere to clinical practice guidelines on a lot of things, the biggest example being low back pain, they're doing a horrible job of it. They're by no means, they're sending all kinds of patients for early imaging. A tiny minority of them are getting physical therapy. A huge proportion of them are getting early opioids, all this stuff. And it's like, that's just as bad. That's arguably in many situations worse than what a lot of the complementary and alternative medicine practitioners are doing. And I would prefer that none of that be happening. But really, I think it's probably unhelpful to single out those kinds of like bad actors in the space. I think that overall, most people in medicine, most people in the personal training world are working to try to help people. But of course, that's not to say that most people in the personal training world are aware of the current physical activity guidelines either. They might just be doing things that make people really sore. They might throw something at somebody that's wildly inappropriately dosed and land them in my ER with rhabdo or something like that.
They might do Murph twice in one day.
I mean, if you were just a total idiot, you might do something like that. so, so I think that there is a large gap to be bridged there, but I don't think that that's something that can be forced on like a national level or something like that. I think it's going to be a more of a local phenomenon, needs to be done, through building relationships. And if I had to guess, that would probably need to involve the trainers going to the physicians than the other way around. I don't envision physicians going out and seeking out trainers that they can refer to. But if you're a personal trainer and you feel, comfortable and confident with what you're doing, then building relationships with physicians is probably going to be a good idea going in that direction. The only caveat is that, of course, what kind of people are the physicians seeing? They might be seeing people with multiple medical comorbidities that you need to be comfortable dealing with in your training practice. I'll say that most medical conditions don't need a ton of fancy, unique, exercise programming or monitoring or something like that. But of course, some of them do have some special considerations. That's the direction I see this kind of heading, is I think that more people in the training space need to be building relationships with physicians, because unlikely that it's going to happen the other way around.
Makes sense. I know you hate that.
We are. We've talked about a lot of amazing things on this podcast. I'm sure we could talk on for like another hour, 2 hours, 3 hours with the way this discussion's going.
Several years, like I've talked with Jason.
Yeah, exactly. But in the interest of time and with respect to your time, we're gonna bring it to the last classic question, which, based on discussion, you will likely hate because it's very reductionist. But it's if you have 2 minutes, you're waiting for your Starbucks, and someone comes up to you, like, "Hey, you're Dr. Baraki, right? How do I get healthy?" What do you say to them?
Oh, okay. So in this situation, they're actually asking me how to be healthy. I think when I saw the initial question, it was like, "How do you tell people how to be healthy?" And I'm like, well, first of all, I don't do that. You don't go out and force this stuff down people's throats. But if somebody asked how they could be healthier, really, I'm going to spend those 2 minutes on what I view as kind of like the highest yield targets, to use a phrase that you guys are going to be intimately familiar with around boards time, right? So I think those are going to have to be the nutrition piece and the exercise piece above just about anything else. I'm certainly not going to spend those 2 minutes talking about getting health screenings done and things like that. But if I can get them from an exercise standpoint, what are my goals? Well, of course, I want to get them doing something. Because again, I'm not going to just spit out the exercise guidelines at them, because I don't know where they're coming from. I don't know what their where their starting point is and what they're willing to do. But what I do think I can get people to do is do some chair sit to stands every single day, if not multiple times a day, if they're willing to do it with some added load, hold a milk jug or something like that. And the reason why I like focusing on that is because the worst case scenario outcome for me in terms of physical disability and frailty is the person who I end up seeing in the hospital who ends up going to a nursing home. Because as you mentioned, the downward spiral, they go there, they end up with, decubitus ulcers, they end up with C. diff, they end up with all kinds of other problems. They get sent back and then back and forth until they die. Mm-hmm. So if I can keep people out of keep them living independently, even if they are not in perfect shape, but if they can live independently and get up out of a chair and take care of themselves, then that's that's like 80% of what I can do for somebody from an exercise standpoint. The rest is, reducing downstream morbidity from other accumulating medical conditions. And that's really my threshold, is if you can get out of a chair, then you have the requisite strength to be able to take care of yourself. You can get off the toilet and get out of a chair. When you can't do that, that's when you end up in a sniff. So my exercise recommendation, I might spend the first minute working on getting them to understand the importance of doing repeat chair sit to stands. As those get easy, they can add weight, pick an arbitrary set and rep scheme, do that every day for the rest of your life, basically.
So 5 by 5.
Sure, that's fine. Because presumably a lot of people that I see are doing none, and I test patients out in the hospital all the time, and they can't get out of a chair once, or they can't do it without using their arms, and that is just a reflection of weak hip musculature, and that is the highway to the nursing home. So I prefer that not happen. The second minute, I suppose, is probably going to be spent speaking on nutrition, and there are obviously a whole boatload of different targets that you can select here. I think if I had to pick one that I would focus on with most of the population in the developed world, it's going to be to eat more plants. I'm not a vegetarian. I'm not a vegan. And I could just as easily say, I want you to eat more protein. I want you to eat more fiber. I want you to eat less saturated fat from animal foods or something like that. But I think that if we could get more of the population here to eat more the fruit and vegetable, that would hopefully displace a lot of other less beneficial things from their diet. It would increase their nutrient intake, probably, compared to a more refined processed diet. It would increase their fiber intake, which itself can protect against other harmful components in the diet. And I think that's probably one of the bigger bangs for our buck that we can get, because I'm more likely to make an impact by asking them to do that compared to just telling them to eat less if they are carrying some excess body fat or something like that, because that's really difficult to do as well and takes a longer conversation than you have there. So those are probably the two big things that I would aim to get some biggest bang for my buck out of people in a 2-minute conversation like that.
And that was the most internal medicine 2 minutes you'll ever hear, guys.
I mean,
not those 2 minutes, I'm like 10.
We could go down hyponatremia if you want to, but I think we're good.
Yeah. Austin, we'll have your socials like all over this when we post it on YouTube and whatnot. But where do you want people to find you? What do you want people to know about you?
Oh, I'm out there. I'm not hard to find. So you can find most of my stuff at barbellmedicine.com, Instagram, Austin_barbellmedicine, and I'm fairly active on Twitter. Not as much of an original tweeter, so much as I am of all the stuff that I read, which is what informs a lot of the stuff that I talk about. I save and retweet there. So I have people who seem to just follow me to be able to see what I'm reading and kind of keep up with that. So I'm just at Austin Baraki there too.
And for those of you who are listening to this, if you find us on YouTube or through the show notes, then you'll be able to find all the links to that. So it'll be easily accessible. So thank you for coming on to the podcast. It was an excellent conversation. We both thoroughly enjoyed it.
Yeah, thanks, man. Enjoyed talking to you guys too.